Hello, and welcome to the July 2022 edition of Urgent Care Town Hall, presented by California Urgent Care Association and sponsored by Cepheid. My name is Claudio Varga, and I'll be your host for today's program. The Urgent Care Town Hall, presented by California Urgent Care Association and sponsored by Cepheid, is a monthly virtual meeting open to anyone and everyone, free of charge, where we share and discuss all things related to urgent care, both in California and nationally. The California Urgent Care Association is the state chapter of the National Urgent Care Association. If you're a member of UCA and located in California, then you're already a member of CALUCA, and we urge and invite you to become more involved with us. There's a lot going on, and we'd welcome your participation. For more information about CALUCA, please visit our website at www.caluca.org. We welcome your feedback and suggestions for future episodes of Urgent Care Town Hall and invite you to be a presenter yourself. Just email us at info@caluca.org. A quick reminder that the annual Western Regional Urgent Care Conference presented by CALUCA is fast approaching and will take place in the breathtakingly beautiful city of Monterey, California, over the weekend of September 17th and 18th. This will be the premier urgent care conference of the fall, and the focus is on timely urgent care topics of importance to the Western region of the U.S. CALUCA would like to encourage all California members to attend, but we'd also like to extend an invitation to all our brothers and sisters from all Western states to come join us. If you're from Oregon, Washington, Nevada, Arizona, Utah, New Mexico, or Hawaii, this is your excuse to come visit Monterey and see iconic destinations like the world-famous Monterey Bay Aquarium and Cannery Row, play a once-in-a-lifetime round of golf at Pebble Beach, or maybe even take a side trip to Big Sur and Hertz Castle, which has just reopened. Bring the family and make some memories that will last a lifetime. For more details about the conference agenda, registration, and room reservations at the Hyatt Regency Monterey Hotel and Spa, please see our website at caluca.org. This event will sell out quickly, so please register and book your room today, and we'll see you in Monterey. We've got a terrific program today with a distinguished guest speaking on a fascinating topic. But first, on behalf of the Board of Directors and our membership, we'd like to thank and welcome Cepheid for their sponsorship of not just today's Town Hall, but of the entire Urgent Care Town Hall schedule for the rest of 2022. Over a decade ago, Cepheid set the standard for innovation in automated molecular diagnostics, and today, Cepheid can boast of having the largest installed base of any molecular platform. Cepheid's new Expert Express CoV2 Plus test provides fast, accurate results in as little as 20 minutes, features 3 gene targets for SARS-CoV-2, offers optimization of N2 probes to enable more reliable virus detection, provides rapid sample-to-answer testing with actionable results from a single sample. So what does this mean to your urgent care practice? It means lab quality results in a simple test at point of care, broader coverage for SARS-CoV-2 variants with 3 gene design, and enables your clinic to effectively manage limited resources with a simple single cartridge technology and easy to use workflow. So remember, the new Expert Express CoV2 Plus test is fast, accurate, and efficient. So please visit cepheid.com today to learn more. Our special guest today will be speaking about a very important topic that is certain to be valuable to all urgent care providers watching. Dr. Rebecca Lillis is a board-certified infectious disease physician practicing in New Orleans. Dr. Lillis's area of expertise in both research and clinical practice is in STIs. She was recently a guest speaker at the American College of Physicians annual meeting, where she provided an in-depth presentation of the updates to the CDC guidelines for STIs. We are very fortunate to have her here today to provide a condensed version of that presentation. Dr. Lillis, welcome to the show. Thank you for sharing your time and expertise with our viewers today. Please tell us about your passion and fascination with this area of medicine and about the work you are doing today.
Sure, let me just open my slides. Let me share my screen. Welcome, everybody. Let me just pull my slides up here.
There you go. You're all set.
Yep. You can put it in presenter view. All right. Good afternoon, everyone. I'm an infectious disease physician from New Orleans, Louisiana, whose area of focus is sexually transmitted infections. I'm sorry, I'm just trying to move the galley view out of the way here. Let's see. I don't know how to do that. Do you know how to move the galley view?
It looks
okay. I got rid of
fine
it.
from
Perfect.
here. Yeah, it looks fine from
Thanks.
here.
All right. So moving on. So clinical questions to be addressed today. We're going to talk briefly about the epidemiologic trends of STIs in the United States. We're going to cover the major changes to the 2021 CDC STI Treatment Guidelines, including gonorrhea, chlamydia, Mycoplasma genitalium, Trichomoniasis, and pelvic inflammatory disease. And then we're going to briefly discuss a vaginitis update. So what is the state of STDs in the United States in 2020? Well, in 2020, an estimated 2.4 million new STIs were reported in the US, and that was a slight decline from 2019, attributable to lower chlamydia rates during the pandemic. There was about a 13% decrease in reported chlamydia rates. And you can imagine that chlamydial infections are usually asymptomatic, with case rates heavily influenced by screening coverage. So during the early days of the pandemic, many healthcare clinics limited in-person visits to patients with symptoms or closed entirely. And it's likely that preventative healthcare visits, where STI screening usually happens, decreased. The STIs that are often symptomatic, gonorrhea and syphilis, saw increases in their numbers. So this slight decline in the rates for 2020 is likely an artifact of reporting and diagnosis. So moving into the STI treatment guidelines, today I'm going to review these through a series of case presentations. Our first case is a 26-year-old cis man who presents to your office Monday morning with a 2-day history of yellow urethral discharge and dysuria after condomless sex with a new partner on Friday night. He reports sex with cis female partners only, both oral and genital sites of exposure. You send pharyngeal and urethral swabs for nucleic acid amplification testing for gonorrhea and chlamydia. What is the preferred empiric treatment for this patient based upon the new guidelines? Would you treat him with Ceftriaxone, 250 milligrams IM plus azithromycin, or would you use a 500 milligram dose of Ceftriaxone plus doxycycline twice a day for 7 days? The correct answer here is B. The new guidelines have increased the recommended dose of Ceftriaxone to 500 milligrams and done away with azithromycin in favor of doxycycline for chlamydia coverage in the setting of gonorrhea. So one of the biggest changes to the guidelines is the change in the recommended treatment of gonorrhea and moving away from this dual therapy that we've been told to use for years. So the recommendation for dual therapy with Ceftriaxone and azithromycin was theoretical, not data-driven. And although the 2-drug therapy with different mechanisms of action might have mitigated emergence of reduced susceptibility to Ceftriaxone, there are concerns regarding the potential harm to the microbiome and the effect on other pathogens that diminishes the benefits of maintaining the dual therapy as recommended treatment. And what we've seen over time is increasing rates of gonorrhea's resistance to azithromycin. And there are concerns that this overuse of azithromycin has led to increases in azithromycin resistance in Mycoplasma genitalium and Shigella. So Ceftriaxone is a bactericidal 3rd-generation cephalosporin with widely variable pharmacokinetics. Its efficacy is best predicted by the time that the serum free drug concentration remains higher than the organism's MIC. Ceftriaxone has been estimated to require concentrations higher than the strain MIC for approximately 20 to 24 hours for effective urogenital gonorrhea treatment. And that 250 milligram dose does not reliably achieve levels higher than an MIC of greater than 1 to 0.125 micrograms per mil for an extended duration. This study was based upon a mouse model and found that the lowest Ceftriaxone dose that was 100% effective at eradicating the susceptible organism 48 hours after treatment was 5 mg per kg. And you can see in the column here what a 5 milligram per kilogram dose is for a different weight patient. So at that 250 milligram dose, if your patient was 50 kilograms, you're okay, which might be okay in California, but in places like Louisiana, where I practice, most of our patients are more in the 80 to 100 kilogram range, which is that 500 milligram dose. So this moved to them recommending the 500 milligram dose for a patient who weighs between 80 to 100 kilograms for a 5 mg per kg dosing. And we've probably been underdosing our patients with gonorrhea for years. So the 2021 guidelines recommend for uncomplicated gonococcal infections of the cervix, urethra, or rectum to use Ceftriaxone 500 milligrams IM as a single dose if your patient's under 150 kilograms or 300 pounds. If you have a patient who's over a gram, who's over 300 pounds or 150 kilograms, you want to give them a gram of ceftriaxone. So that's 4 times the dose we'd been treating some patients with a few years ago. Recommendations for alternative regimens. If ceftriaxone is not available for the cervix, urethra, or rectal infections, you can use gentamicin 240 milligrams IM plus azithro or a single dose of syphilisine. Now, if you have patients for either the regimen with just ceftriaxone or syphilisine that you need to also include chlamydial coverage for, like our case, if you're not sure whether or not they might not have chlamydia in addition to gonorrhea, then you're to use doxycycline 100 milligrams twice a day for 7 days to cover for chlamydia. So both his urethral and pharyngeal swabs are positive for gonorrhea. What are the CDC recommendations for test of cure? Is no test of cure recommended? Should we perform a test of cure at his pharyngeal site only in 7 to 14 days? Or should we perform a test of cure at both sites that were infected in 7 to 14 days? So the recommendations of the CDC are that you only need to do a test of cure for the pharyngeal site of infection, and it is recommended to be done in 7 to 14 days. You can use either culture or nucleic acid amplification tests for this test of cure. Just a word of caution, if you're using NATs for test of cure, you might want to wait till more like 10 to 14 days so that you don't pick up residual bacterial DNA or RNA on your test. So pharyngeal gonorrhea infections are less often screened for than other anatomic sites, and most reported ceftriaxone treatment failures have involved treatment of pharyngeal gonorrhea. It's thought that interactions among other bacteria in the oropharynx with gonorrhea and sharing of DNA lead to the acquisition of resistance. So this strengthens the recommendation for increasing the dose of ceftriaxone to 500 milligrams. For pharyngeal infections, the only recommended treatment is ceftriaxone. If you have a patient who can't take ceftriaxone for whatever reason, you really want to, if they report an allergy to beta-lactams, you really want to delve into that allergy and see if it's a real allergy or one of those allergies where maybe, they had a rash as a child, but it really isn't significant, because there are really no alternative treatments recommended for pharyngeal gonorrhea. And again, any pharyngeal gonorrhea, you want to perform a test of cure on. So follow-up testing, pharyngeal gonorrhea, test of cure with culture and NAT in 7 to 14 days. Now, for all sites, reinfection within 12 months ranges from 7 to 12%. So persons who have been treated for gonorrhea at any site should be retested. That's rescreening, not test of cure, 3 months after treatment. Pharyngeal infection, you need to do a test of cure. Any site of infection, you want to rescreen in 3 months. Our next case is a 26-year-old cis man who presents to your office with a 1-week history of clear urethral discharge. Microscopy is positive for 5 to 10 white cells per oil immersion field. What is the recommended treatment? Doxycycline, 100 milligrams twice a day for 7 days, or azithromycin, 1 gram by mouth once. The correct answer here is doxycycline. This patient has non-gonococcal urethritis based on his microscopy, which is most commonly caused by chlamydia. The 2021 guidelines have shifted away from azithromycin as the initial therapy of most STI presentations, including non-gonococcal urethritis. Doxycycline is now the preferred treatment for chlamydia. So what is the case against azithromycin? Well, first we're going to talk about chlamydia. This study done by Geisler's group was a randomized controlled trial comparing oral azithromycin, the stat dose of 1 gram, with doxycycline 100 milligrams for 7 days for the treatment of urogenital chlamydia in adolescents who were in correctional facilities. There were no treatment failures in the doxycycline group, but in the azithromycin group, there were 5 treatment failures. So the efficacy of azithromycin was 97% versus 100% for doxycycline. And this is for urogenital infections. And they basically found that azithro was inferior to doxycycline for the treatment of genital chlamydia. So there's an even bigger difference when you start to look at rectal infections. The initial data for this was retrospective. Keep in mind, rectal chlamydia is the most common STI in men who have sex with men. Retrospective studies found persistent rectal infections in 22% of people who were treated with azithromycin versus 8% of those treated with doxycycline. A later meta-analysis of 8 observational studies found the random effects pooled efficacy for azithromycin was around 83% versus about 100% for doxycycline. Then Julie Dombrowski and her group published a study in September that was a randomized controlled trial for rectal chlamydia treatment in men who have sex with men. And she found that doxycycline cured 100% of rectal infections at 4 weeks versus only 74% that were cured by azithromycin. So that 1 week course of doxycycline was significantly more effective than a single dose of azithromycin for the treatment of rectal chlamydia in men who have sex with men. Those authors concluded that azithromycin performed so poorly that even in the context of expected imperfect adherence to doxycycline, it would be a better treatment for rectal chlamydia. So what about women? The FemCure study was performed in the Netherlands, and it was a prospective cohort study that assessed the effectiveness of doxy and azithro for the treatment of rectal and vaginal chlamydia in women. The treatment consisted of doxycycline, the standard 7-day dose, in rectal chlamydia positive women versus azithromycin in vaginally positive women who were either rectally untested or rectally negative. And what they found was that for the rectal infections, 78.5% cure was achieved in the azithromycin treated women versus 95.5% in the doxycycline treated women, for a 17% difference. Doxycycline was more effective than azithromycin in treating rectal infections in women. And interestingly, there were 209 cases of rectal chlamydia detected in women who did not report symptoms of condomless receptive anal intercourse. And this demonstrates that selective rectal testing policies may miss many untested rectal infections that are subsequently treated with azithromycin for vaginal chlamydia. So these authors recommended universal rectal testing and universal use of doxycycline as treatment for chlamydia. So the weight of the evidence has shifted in favor of doxycycline. The current recommendations for the guidelines for uncomplicated infections of the pharynx, rectum, and urogenital system for chlamydia should be treated with doxycycline 100 milligrams twice a day for 7 days. As an alternative, you can use the 1 gram dose of azithromycin. For pregnant women, azithromycin is the recommended treatment because of the issue with doxycycline and the deposition in the teeth of the fetus. You might want to also consider using azithromycin in women of childbearing potential who are not on a reliable form of contraception if you're not able to do pregnancy tests in your clinic. And it may also be preferred in cases where compliance is an issue or in adolescents who are concerned about their parents finding a prescription bottle. Keep in mind, if you treat any rectal infection with azithromycin, you do need to do a test of cure. Our next case is a 27-year-old cis man with HIV who presents to your clinic with complaints of rectal discomfort and bloody discharge for the past 2 weeks. A month ago, he was seen at another clinic for a 2-week history of lower abdominal discomfort and rectal pain and prescribed Ceftriaxone 500 milligrams IM plus doxycycline for 7 days. He reports his symptoms improved, but then returned once he completed his treatment. His rectal swab from the visit resulted positive for chlamydia. He reports no sex for the past 2 months. On exam, a mucoid rectal discharge is noted, and the rectal swab is collected has blood-tinged discharge on the swab. In addition to testing this patient at all sites for gonorrhea and chlamydia and sending syphilis serology, what is your plan for the treatment of this patient? Would you retreat for gonorrhea and chlamydia? Would you retreat for gonorrhea only? Would you treat for possible lymphogranuloma venereum with doxycycline 100 milligrams twice a day for 21 days? The correct answer here is to treat for LGV. So the patient presented with proctitis and a bloody rectal discharge and probably should have been treated initially for LGV in the setting of a positive rectal chlamydia test, particularly in a person living with HIV. So the CDC guidelines for acute proctitis recommend what this man was given initially, Ceftriaxone in a single dose, plus doxycycline, 100 milligrams, 2 times a day for 7 days. But the doxy course should be extended to 21 days in the presence of bloody discharge, perianal or mucosal ulcers, or tenesmus and a positive rectal chlamydia test. So how do we tell the difference between rectal chlamydia and lymphogranuloma venereum? Well, just to talk about lymphogranuloma venereum for a moment, it's caused by Chlamydia cerevars L1, L2, and L3. And most nucleic acid amplification tests on the market just give you a positive, so you don't know what serovar of chlamydia you're dealing with. An Australian study found that 34% of rectal LGV infections were asymptomatic. The prevalence in symptomatic proctitis is 23 to 48%, depending on where you're practicing. Outbreaks have been increasingly reported among men who have sex with men, particularly those with HIV. It causes a lymphoproliferative reaction classically associated with inguinal lymphadenopathy, and there are recent case reports of cervical lymphadenopathy associated with pharyngeal infection. The inguinal lymphadenopathy, however, may be absent in clients with rectal infection, so you can't just look for that to look for cases of LGV. You have to look a little further. Primary infection is a painless genital ulcer or mucosal inflammation, and the incubation is typically 3 to 12 days. Secondary infection extends to the regional lymph nodes about 2 to 6 weeks later. It can cause an inguinal syndrome with inflammatory reaction in the superficial and deep inguinal nodes, causing the characteristic groove sign. And it can cause an anorectal syndrome with symptoms of proctitis with rectal discharge, anal pain, constipation, fever, and/or tenesmus. Late infection causes fibrosis and strictures and destruction of the infected tissues and can mimic inflammatory bowel disease. Oral pharyngeal infection has also been reported mostly in men who have sex with men with painful cervical lymphadenopathy. And here are just a few pictures of LGV. The image on the left of your screen is the classic groove sign. So you see the swollen lymph nodes on either side of the inguinal lymph ligament. This is a gentleman who had cervical LGV, and you can see the swollen node in his neck. This was associated with a pharyngeal chlamydia infection. So the diagnosis in the US is based on clinical suspicion, epidemiology, and a positive chlamydia NAT. Serology has no role in the diagnosis of LGV. Presumptive treatment is recommended for LGV and symptomatic proctitis. Men who have sex with men with bloody discharge, perianal ulcers, or mucosal ulcers, and a positive rectal chlamydia NAT and/or HIV infection should be treated as LGV. The optimal treatment duration is based on historical precedent, and it's recommended 3 weeks of doxycycline twice a day. Some state health departments do have LGV nucleic acid amplification testing available to tell you which serovar you have, but many people won't have access to that. And ideally, all positive rectal chlamydia NATs should have reflex testing for LGV, in my opinion, but that's not available at this time. Our next case is a 36-year-old cis man who presents to your office 1 week after completing a 7-day course of doxycycline for non-gonococcal urethritis. His original test results were negative for gonorrhea and chlamydia. He reports his discharge improved initially, but returned a few days ago. He reports sex with cis men only, but no sex since he started his original course of antibiotics. What is the most likely diagnosis? Mycoplasma genitalium, Chlamydia trachomatis, or Trichomonas vaginalis? The correct answer here is Mycoplasma genitalium. It's unlikely that a chlamydia infection would be negative on NAT and fail doxycycline treatment. And Trichomonas vaginalis is incredibly uncommon in men who have sex with men. Mycoplasma genitalium, however, is the second most common cause of NGU after chlamydia. It's the most common cause of persistent urethritis. It's implicated in cervicitis, endometritis, PID, and infertility in women. It's frequently asymptomatic. There's no dedicated public health program in the US. There's no screening recommendations in the US, and it's not recommended as initial testing in symptomatic individuals in the United States. There is an FDA-approved nucleic acid amplification test available for urogenital specimens, and many commercial labs have laboratory-developed tests. So you suspect Mycoplasma genitalium. What is the CDC recommended treatment? Azithromycin, 1 gram today, followed by 500 milligrams for 3 days, or moxifloxacin, 400 milligrams daily for 7 days, or doxycycline, 100 milligrams twice a day for 7 days, followed by moxifloxacin, 400 milligrams daily for 7 days. So the correct answer is doxycycline for 7 days, followed by moxifloxacin for 7 days. At first glance, that sounds like a lot of antibiotics, but let me explain how the CDC arrived at this recommendation. So back in the early days of Mycoplasma genitalium, in the late 1990s, early 2000s, we realized that doxycycline didn't work very well for it, with poor efficacy and cure rates between 30 to 40%. The next thing we realized that azithromycin as a 1 gram single dose had a cure rate of 85%. But after you use that 1 gram dose for empiric treatment, macrolide resistance can be found in about 30 to 45% of subsequent samples. So then we went on to think we could use an extended course of azithromycin to treat most MG, but we kept finding increased resistance rates. So the bottom line here is empiric use of azithromycin for syndromic management of STIs has probably led to these increases in macrolide resistance in M. genitalium. Once you use that 1 gram dose for your patient, you shouldn't use the extended course of azithromycin for M. genitalium. So why are we going to start with doxycycline if it's only 30 to 40% effective? Well, this study done in Australia looked at the bacterial loads of M. genitalium in 56 men with urethritis. What they found was that after that week of doxycycline, those bacterial loads were undetectable in 39% of patients, reduced in 50%, and increased in only 6%. So while doxycycline will not cure most MG infections, it can significantly reduce the bacterial load, making it easier for the more effective antibiotics to do their job. This also strengthens the argument for using doxycycline for first-line treatment of syndromic STIs in the place of azithromycin. So this trial done in Australia looked at this resistance-guided therapy for treatment of MG using doxycycline followed by moxifloxacin, or doxycycline followed by an extended course of azithromycin. So what they did was patients with STI syndromes were treated with doxy for 7 days and recalled if their MG test was positive. They ran macrolide resistance testing, and if macrolide susceptible, the patients received an extended course of azithromycin over the next 4 days. Resistant cases received moxifloxacin for 7 days. Test of cure was done at 14 to 28 days after treatment, and microbial cure for doxyazithromycin was 95.4%, and doxymoxifloxacin was 92%. Dual class resistance, meaning to both the quinolones and to azithromycin, was present in 16% of those samples in the doxymoxifloxacin group. And still, they achieved a 92% cure. So that actually worked pretty well. So resistance-guided Mycoplasma genitalium therapy is what Europe and Australia do. They use doxycycline for syndromic management of STIs. So when your patients come in with urethritis or cervicitis, you start with doxycycline. They test symptomatic patients for MG and perform macrolide resistance testing if it's positive, which is available in Europe and Australia. Then they treat with azithromycin extended course if it's not resistant. And if it is macrolide resistant, then they use the fluoroquinolone like moxifloxacin. This is supported by research out of Australia, and Europe and Australia routinely test symptomatic patients for MG, but we are not doing that presently in the United States. So the CDC's treatment guidelines for 2021, if macrolide resistance testing is not available, which in most practice settings it will not be, you're going to use doxycycline 100 milligrams twice a day for 7 days, followed by moxifloxacin 400 milligrams orally for 7 days. If macrolide resistance testing becomes available, you would start with doxycycline, and then if macrolide sensitive, you could use that extended course of azithromycin. If macrolide resistant, you're going to use moxifloxacin. So the resistance rates for M. genitalium in the United States for macrolides are upwards of 50%. For quinolones, the resistance rates are around 11%. So we're not going to hear the end of Mycoplasma genitalium. And once we start screening more for it and testing more in symptomatic patients, I think then we'll really realize how big our problem actually is here in the US. Our next topic is trichomonas. What is the CDC recommended treatment for trichomoniasis in women? Metronidazole 500 milligrams twice a day for 7 days, or metronidazole 2 grams once, or either A or B. The correct answer in the 2021 guidelines is that all women with trichomonas should be getting metronidazole twice a day for 7 days. The 2 gram dose is no longer recommended. This is based on this trial by Patty Kissinger, who compared the 7-day course to the 2 gram dose and found that at test of cure, the recurrence rate was twice as high in the women who got the single dose of metronidazole. So this resulted in a change in the guidelines. So women should receive metronidazole 500 milligrams twice a day for 7 days. An alternative is tinidazole, and men are still being given the metronidazole 2 gram dose because there hasn't been a trial to prove that that doesn't work as well for them. Clearance of trichomonas outpatient treatment for PID were ceftriaxone plus doxycycline for 14 days with the option of adding a 2-week course of metronidazole. This is changed in the 2021 guidelines based on the following study. The study compared single-dose ceftriaxone and 14 days of doxycycline to the same regimen with the addition of 14 days of metronidazole in women with acute PID eligible for outpatient treatment. Women aged 18 to 40 who were enrolled and met criteria for outpatient treatment, improvement was reported in pelvic pain was similar between the two groups, but pelvic organ tenderness on exam was still present in 20% of women who did not receive metronidazole. Fewer women treated with metronidazole had pelvic tenderness at 1 month, and the addition of metronidazole was associated with significantly less frequent recovery of anaerobic organisms from the upper genital tract, decreased M. genitalium, and with improved clinical response compared to ceftriaxone and doxy alone. So the addition of metronidazole may be needed to effectively eradicate anaerobic pathogens from the upper genital tract of women with PID. So the new recommendations are to use ceftriaxone plus doxycycline for 14 days, plus metronidazole for women with PID in an outpatient setting. So a summary of the STI guidelines update. For gonorrhea, we're now using ceftriaxone 500 milligrams IM if your patient is less than 150 kilos. We want to perform a test of cure for all pharyngeal infections. For chlamydia, we're going to start with doxycycline treatment, 100 milligrams twice a day for 7 days. If pregnant, use azithromycin, and consider LGB treatment for symptomatic rectal infections. For Mycoplasma genitalium, you'll start with doxycycline for 7 days, then moxifloxacin for 7 days, unless resistance testing is available. For Trichomoniasis, the recommended treatment for women is metronidazole 500 milligrams twice a day for 7 days. For men, we're still using the 2-gram dose. For PID, we're going to use ceftriaxone plus doxycycline for 14 days, plus metronidazole for 14 days. So now we're going to move into a discussion of vaginitis, or as the CDC guidelines call it, diseases characterized by vulvovaginal itching, burning, odor, or discharge. The majority of women will experience at least one episode of vaginitis during their lifetime. Medical history alone is insufficient for accurate diagnosis of vaginitis and can lead to inappropriate treatment. I don't know about you guys, but I always get messages from patients. I have another yeast infection. I have BV. Can you call me on a prescription? And I unfortunately tell them, no, please come in. Let's assess what's going on and treat you based upon, the microscopy, the findings that we have based on your testing, not just your symptoms. A careful history, examination, and laboratory testing to determine the etiology of these symptoms is warranted. Infections most often associated with vaginal symptoms are bacterial vaginosis, trichomoniasis, and vulvovaginal candidiasis. So traditional diagnosis of vaginal symptoms has relied on a number of different things. AMSL's criteria for BV requires vaginal exam to describe the characteristic discharge, pH paper to record pH, and the ability to perform microscopy to look for clue cells. Microscopy is only about 50% sensitive for the diagnosis of trichomonas when compared to NAT. And for yeast, it's only about 50% sensitive also when compared to culture. So microscopy alone cannot rule out yeast or trichomoniasis. And the CDC has been recommending nucleic acid amplification testing for the diagnosis of trichomoniasis since the 2015 guidelines. So BV is a vaginal dysbiosis resulting from replacement of normal hydrogen peroxide and lactic acid producing lactobacillus species with high concentrations of anaerobic bacteria. These anaerobes include Gardnerella vaginalis, Prevotella species, Mobolunca species, Atotopium vaginae, and other BV-associated bacteria. And it's really interesting that several of these bacteria weren't even discovered until we started doing molecular methods for bacterial detection. Originally it was thought that Gardnerella vaginalis equaled BV, but it's just the easiest thing to culture. And once you look at molecular methods for the detection of bacteria, they discovered Atotopium vaginae and 2 different BV-associated bacteria that are really more of the problem than the actual Gardnerella, which can be found in healthy vaginal fluid as well. BV is the most common cause of vaginal discharge worldwide. So diagnosis of BV by traditional methods, you use clinical criteria or AMSL's criteria, and you must have 3 or 4 of these. The pH over 4.5, greater than 20% clue cells on wet mount, or a positive whiff test, and then that characteristic homogeneous vaginal discharge. Another way to diagnose it is use Nugent score from a vaginal gram stain, but that's a little bit labor intensive and you have to be specially trained to read those. The sensitivity and specificity of Ansell's criteria are 37 to 70% and 94 to 99% when compared to Nugent score. So we're now moving into the era of molecular diagnosis of BV. Several companies have developed multiplex PCRs for the diagnosis of BV. Two NATs are presently FDA cleared, the BD Max vaginal panel and the Aptima BV assay. These tests should only be performed on women with symptoms, and none of these tests are point of care, unlike microscopy. So now we're going to talk about Cepheid's new assay for vaginitis. The Expert Express MVP test, performed on the GeneXpert instrument systems, is an in vitro diagnostic test for the detection and differentiation of DNA from organisms associated with BV, Adenotovium species, bacterial vaginosis-associated bacterium, that's BVAB2, and Megasphaera. It also detects Candida species, those that are easier to treat, like Candida albicans, Candida tropicalis, Candida parapsilosis, and then separates out the more difficult to treat ones, Candida glabrata and Candida krusei. It also detects Trichomonas vaginalis. So all of these organisms in one test. The Expert Express test uses clinician-collected and self-collected vaginal swabs from patients who are symptomatic for vaginitis and vaginosis in the clinical trial. The objective of the trial was to determine the clinical performance of the test in symptomatic population using both clinician-collected and self-collected vaginal swabs relative to other established comparators. The swabs were collected from 1,488 participants over 14 years of age, presenting with signs and symptoms of vaginitis or vaginosis in a multi-site trial. There were 12 geographically diverse locations in the US, including 9 point-of-care sites. The testing was performed by both trained and untrained users. And they're not kidding when they say untrained users. They basically ship you the machine with instructions on how to put it together and run the test, and you go. And that's the extent of the testing for the untrained users. The results from the Expert Express test were compared with established comparators. For BV, it was the BD Max vaginal panel. For the Candida group, it was the yeast cultured, followed by MALDI-TOF for identification. For Candida glabrata and krusei, it was MALDI-TOF mass spectrometry for species identification. For Trichomonas, the patient-infected status algorithm was based on the results from an in-pouch culture and the BD Max vaginal panel. So the most common age in the group was 18 to 29, and 50% of the women in this trial had recurrent symptoms. And here's the results for the overall performance. So in the clinician-collected swabs, the sensitivity for BV diagnosis was 93.8%, and very similar on the self-collected, it was 94%. For the Candida group, the broader group, it was 98%. And for clinician collected, and 97.5% for self-collected. For Trichomonas, it was incredibly sensitive with 97.3% in the clinician collected and the same result, 97.3% in self-collected. So how did trained and untrained users do with this test? Well, there was no statistical difference in the performance of the test when done at the point of care by an untrained user or in a lab-based setting. You can just see those columns there. The trained users are in yellow and the untrained users are in purple. And this is comparing the clinician collected and the self-collected swab. So it really worked well across the board. And this is just a bar graph of the same results, just depicted in a different manner. So for the clinician collected swabs are in blue with trained users in the lighter blue and untrained users in the darker. And then the self-collected swabs are in the orange. So the Expert Express multi-MVP test had a high levels of agreement with established comparators. Both the clinician-collected swabs and self-collected swabs had comparable sensitivity and specificity results. And the self-collected swab was always done first, which would put the clinician-collected swab at a slight disadvantage because it was randomized in order with 3 other tests. The expert test performance was similar in the hands of trained versus untrained users, and it performed well at the point of care. So this test, which provides results at the point of care in under an hour, is an exciting new tool in the diagnosis of vaginitis. And that's the end of the presentation. So if anyone has any questions, I'd be happy to answer them.
Hey there, Dr. Lillis. That was very, very, very interesting. I don't have any questions myself, and this is a little bit more clinical than my pay grade. My pay grade. I was telling Scott, but I'm waiting to see if he wants to come on and have a little chat with you. Let's see. I can't think of anything. It has been a little. Okay, yeah, we're trying. So tell us a little bit about. Just maybe for me, I'm a non-clinical person, a day in the life of what you're doing now. I mean, what have you seen any changes and trends in populations now that we're kind of coming out of COVID? I mean, what's been going on? I know, COVID you mentioned it early on, just a quash on just sheer volume. So there wasn't as much visits, but what are you starting to see now? People, out and about now and some changes and your encounters?
Sure. So our clinic had opened back up pretty quickly, like in May of 2020, after the initial wave of COVID. And we were seeing a lot of STIs at that point. So people with symptoms coming in. So gonorrhea, syphilis, a lot of new HIV diagnoses also, unfortunately. A lot of people during the pandemic, especially the early days in 2020, fell out of care on their PrEP as well, which is a bit of a problem. So we've been referring people back to care. We're seeing a lot of extradental STIs, throat and rectal gonorrhea and chlamydia. So I think things are pretty much back to normal here in my STI world. So I'm sure the urgent care providers are seeing a fair share as well.
Yeah, I would think so. Oh, there's Scott. Scott, what do you think? What have you been seeing up in your neck of the woods?
Yeah, we seem like we're getting tripped back to a normal, I guess, if you want to say it, as far as the number of people coming in. I had a question, Dr. Lillis, and you may have already said this in the presentation, I apologize. What's the turnaround time for most of these tests on the Cepheid machine?
It's 40 minutes, actually. So the package insert says up to 60 minutes, but having run hundreds of them myself in the clinical trial, I would say that it's right around 40 minutes. It gives results. So when you compare like the labor intensivity of like having to maintain a microscope and do microscopy on patients and train everyone in your clinic to perform microscopy successfully, it really is a valuable tool.
So tell me a little bit about your patient flow. And you've got a test cooking for 40 minutes. Are the patients leaving and coming back? Are they staying there in the clinic? How do you handle that?
So we were just doing this test as part of a clinical trial. We haven't implemented it. So as a clinical trial, you're not using those results to treat the patient. I would imagine the thing to do would be to have the patient self-collect the swab early on, so you have whoever's, checking the patient in, get their chief complaint. If they're complaining of a vaginitis syndrome, you could have them do a self-collected swab, start the test running before you even talk to them potentially, and then you may have results by the time you're seeing them.
Gotcha. Okay.
And alternatively, if you would want to interview the patient first, you could interview them, have them collect the swabs, and have them wait in the waiting room for their results.
Okay. We do have a question in the chat, and someone's asking if the slides of the presentation are available.
They'll be recorded.
Okay. All right. So I guess I should tell everyone that this town hall is recorded, and the recording will be available.
And the guidelines presentation, all of the guidelines are available at the CDC website. So they've got some quick guides on the website that are really easy to access. They have an app that you can access, so that makes it all very easy.
Okay. All right.
The CDC.
Thank you. All right.
Yeah, I'll just mention to everybody, if you go to, we have a a YouTube channel, which is CALUCA.org, and all of the town halls live there, and they can be watched as many times or by anyone. We do have a question that came in through the Q&A function here. It says, can you summarize the tests that typically must be sent out simply because urgent care settings don't perform these tests on site? So that might make sense to you. I mean, what are the tests that that in your experience, they just can't, they're important tests and they just can't be handled, in-house, that absolutely have to be sent out?
Well, I mean, if you have point of care testing available, then you can do it in-house. So there's platforms you can do in-house for gonorrhea and chlamydia gnats, as well as for vaginitis diagnosis. But, if you have a patient, you're testing for gonorrhea, you want to test for gonorrhea and chlamydia if they're sexually active. And you also want to include pharyngeal and rectal testing if they have sex at those sites. And basically any men who have sex with men, you probably want to do triple site screening regardless of what their history is. I see a comment in the chat that the moxifloxacin recommendation would violate our organism, strongly discourage the use of quinolones. The problem is for Mycoplasma genitalium, there is literally no other treatment. You don't have a choice. So, the recommendation to avoid quinolones in infections like respiratory infections and urinary tract infections, where there are a slew of other appropriate antibiotics, is probably really what your organization is focusing on, not using it when you have a documented diagnosis of Mycoplasma genitalium. Yeah, but if you don't have microscopy in any urgent care, then you're going to need to send out a vaginitis panel to diagnose BV and yeast. And you always have to send a NAT for Trichomoniasis. So, if this test that Cepheid, we did the study for, they're working on getting it FDA approved right now. And it's going to run on the expert machine, just like all the other respiratory panels and everything else. It's a cartridge-based test. So it would be really easy to implement at point of care in your clinics where you'd get results same day. And most women coming in with vaginitis are going to expect a prescription before they leave clinic. So it kind of defeats the point of like sending out a test to the lab that you're going to get back in 3 or 4 days, because those women aren't going to accept not getting a prescription when you're seeing them, if you know what I mean.
Customer service issues. Yeah.
Yeah, they're there for treatment. So they would like to know what they have and they would like to be treated that day. So the point of care testing is the most exciting thing to me about this assay, the ability to do it where the patients are and get them results within an hour.
Makes sense. Yeah, thank you.
Do you have any preference for the self-collected versus the clinician-collected sample?
Yes, I prefer self-collected, honestly. It's so much easier. You can instruct patients. There are many handouts. Anybody who makes a vaginal swab test will make a handout to like put on the wall to show patients how to do it correctly. And the patients actually like it. So we have a lot of frequent flyers for STI screening who come in like every couple months. And, as a woman, when you're going to the doctor, you're like, oh God, I'm going to have to get on the table. I'm going to have to get undressed. I'm going to have to do an exam. And if you're just really there for a frequent screening, not like an annual well woman visit, that's not really 100% necessary if you're depending on what kind of symptoms you're having. So self-collected swabs for gonorrhea, chlamydia, trichomoniasis screening, and we're using them also for BV and yeast now too. I find that my patients really enjoy, well, I don't know if enjoy is the right word, but they are happy to have that option. And the other patient population too is gender diverse individuals who may have had negative healthcare experiences in the past and aren't necessarily trusting healthcare providers to do exams, might prefer a self-collected specimen.
How about for the triple site testing?
Self-collected also. It's acceptable.
Great.
Patients do very well with it.
Nice. That's good to know. Thank you.
Mm-hmm.
Thank you, Dr. Lillis. We really, really appreciate that. So, any closing thoughts?
No, screen for STIs. They're out there. I think the thing that's on the cusp right now for STI management is what to do about Mycoplasma genitalium. If we're not screening people, well, don't screen for it, but not testing all people who come in with symptoms. It's just going to be interesting in the years moving forward to see how much of it is out there, if we think it's causing about 20% of urethritis.
Got it.
Yeah.
Super. All right. Scott, parting shots?
No, my questions were answered. I thought it was a very, very thorough talk. I really appreciate it.
Definitely.
I actually learned a lot. Oh, great.
Great.
Thank you.
Yeah, we were just talking the other day, like, how do you keep up to date? So that's a good question. I'm going to ask that question. Mm-hmm. It was a conversation with a group of providers, and they were just talking about just how do you stay up to date? You learn how to do something and you kind of you stick with it, you get good at it. And then, you find out, oh, they changed it again. And, what are
Yeah.
some of your thoughts on some practical advice for providers? I mean, how do you stay up to date?
Yeah, keep an ear to the ground whenever a new guidelines is coming out. The CDC doesn't change them that often, fortunately. So like the last ones we had were 2015. These were supposed to be 2020, but obviously this more was going on in 2020 than any of us anticipated. So it got pushed back to 2021. So, every 5 years to update a guidelines, just keep up to breast with that. I mean, any kind of topic where it's your field, get your journal in your field, read the table of contents, the stuff that's interesting, read those articles. I know we can't all read every journal all the time, but like I skim things, and then, if it's relevant to my field of STIs, I'll pull it out. I'm also an infectious disease doctor. So, interesting updates in sepsis or things like that affect my hospital practice, I'll pull those out and read them. I get paper journals. I guess I'm dating myself at that point. But if, you can look online and mark the articles when you get those emails about things that are, updated and coming in. But I'd say staying on top of the guidelines, and then going to your society conferences too. Those are a good place to get updates. For infectious disease doctors, IDSA, the ACP annual meeting has a lot of good updates. I'm sure urgent care, your update in Monterey sounds fantastic.
You should come and see us.
Yeah, I wish I could.
All right, we'll see.
Yeah.
Well, thank you. Thank you again, Dr. Lillis. We really appreciate it. So again, for everybody, our guest today was Dr. Rebecca Lillis, and we are definitely indebted to her for her generous sharing of her time and expertise with us today. So again, I want to remind everybody that we're just 2 months away, almost exactly, from the Western Regional Urgent Care Conference in Monterey, California. So come and see us. It's going to be a terrific 2-day program, and there's all kinds of great things to see and do in the Monterey Bay area. And for more information, just come and see us at CALUCA.org. And just a quick reminder, our next town hall will be next month, Thursday, August the 11th at the same time, 12 noon Pacific Standard Time. Until then, everybody take care, be safe, and thanks again for joining us. Bye-bye.
Thank you. Bye, guys.
Thank you.